Good morning. The Senate Special Committee on Aging will come to order. Welcome, everybody. Welcome to the committee's 8th hearing of the 118th Congress about drug development for rare and serious diseases. As is the tradition of the committee, the Aging Committee Ranking Member Braun in this case, will offer an opening statement.
Thank you, Senator. Thank the witnesses for coming and for all the folks from around the country here today. There are over 7,000 rare, progressive, and serious diseases known to man. It's estimated that 95% lack treatment. Yet in my time as senator, there's not been one Senate hearing to examine promising therapies for people with rare, progressive, and serious diseases. The room is packed with people, patients, and caregivers that live this reality every single day. Right here, 350 patient stories from 44 states. This is long overdue. People that watch their bodies deteriorate in real time. Family members who have seen their loved one go from the picture of health to knocking on death's door. Parents that buried their children before they even started school. I want to recognize and thank each one of you that are here in the audience and let you know I think this is the beginning of a new day for what we're all interested in. Chairman Casey, in response to this hearing, our committee has received these letters, 350 of them, 44 states, with personal experiences. I ask by unanimous consent that we enter these into the record.
Without objection.
Thank you. A wide variety of disease groups are represented in these submissions, including ALS, DIPG, an extremely aggressive pediatric cancer, and Barth syndrome, an ultra-rare genetic disorder that regularly results in death from heart failure before a child's 5th birthday. Importantly, none of the diseases that our constituents have contacted us about have any form of FDA approval treatment, not one of them. These diseases are relentless, they're widespread and devastating. Most are considered a death sentence, but they are not invincible, and our constituents are not helpless. Patients deserve a promising pathway at the FDA. Today, I'm joined by Senators Gillibrand, Wicker, Kramer, Murkowski, Manchin, and Warnock in sponsoring the Promising Pathway Act to create a more flexible, accessible, and compassionate drug approval system at the FDA. And if there's any indication from the over hour and a half I spent on the Senate floor yesterday, we're going to be getting a lot more senators on this bill. The Promising Pathway Act would create a rolling, real-time drug approval pathway to speed access for individuals with these rare diseases. This bill does not undermine patient safety or FDA's gold standard for drug approvals in any way. Therapies developed through the pathway will be rigorously evaluated and continuously studied using real-world data. I ask unanimous consent to enter into the record a letter of support for this hearing signed by 15 individuals and organizations.
Without objection.
The Promising Pathway Act is a common sense step to give the FDA the flexibility it needs to serve Americans with these most trying diseases. Our constituents continue to fight for new treatments, greater access, and full lives. I ask my colleagues to join me in unlocking hope for these constituents. I yield back to you, Senator Casey.
I want to thank Ranking Member Braun. Of course, he worked to put this hearing together, and his staff and our staff, and I'm grateful for your work on this. This is a topic that's obviously meaningful to everyone in this room and every member of the committee, and we look forward to a robust discussion about this topic today. As Ranking Member Braun outlined, rare diseases are those that affect some 200,000 Americans, and over 7,000 rare diseases have been identified. 7,000. While each individual rare disease may affect only a small number of people, collectively, it's estimated that some 25 to 30 million Americans are living with a rare disease. We've done a lot of research into and drug development for these rare diseases. In 1983, prior to the passage of the Orphan Drug Act, there were just 38 drugs approved to treat rare diseases. In the 40 years since, we have over 1,100 new drugs or new indications for drugs approved for rare diseases. I'm proud to have worked on legislation entitled the Creating Hope Act to incentivize the development of drugs for rare pediatric diseases in particular, and other legislation to address some of the challenges faced by those living with what you might call ultra-rare diseases, which affect even a smaller number of people. My legislation, the Creating Hope Act, captures what we as legislators are trying to do, to give Americans living with rare diseases hope for the future. And while we've made some progress, many challenges remain, as we'll hear from our witnesses today. Too many people living with and dying from rare diseases still do not have FDA-approved therapies to treat or mitigate their conditions. I believe that every one of these individuals deserves access to an FDA-approved, safe, and effective therapy. So we must make sure that research continues and that clinical trials are designed to allow effective therapies to reach patients as quickly as possible. Rare diseases and the research and clinical trials for drugs to treat them are fundamentally different from more common conditions. We'll explore some of those differences today and the ways in which they present challenges for drug development through our witnesses and their testimony today. It's important to note that my observations on the challenges facing the rare disease community and the steps we might consider to address these challenges don't necessarily apply to other non-rare conditions. But as we'll hear today, the challenges for drug development start from the earliest stages of development. When patient populations are small, it's hard for clinicians and researchers to develop what is known as a, quote, natural history, unquote, for the disease, and what the trajectory of the disease is when it is not treated. Natural histories are important for developing therapies because if you don't understand how a disease progresses, it's hard to measure whether a new therapy is working. Rare diseases often are heterogeneous, meaning that not every patient disease will progress in the same way, compounding the problem of poorly understood natural histories. Once a promising drug candidate makes it to clinical trials, there are further challenges. Drugs intended to treat common conditions are tested in hundreds of thousands of people. When your entire patient population is only a few thousand or a few hundred or a few dozen, it's simply not possible to do the same type of clinical trials. And when you have smaller trials, it's more difficult to demonstrate efficacy. In recent years, the FDA has taken action to improve how it works with companies developing drugs for rare and serious conditions. And the agency has done a lot more work to hear directly from patients affected. More recently, the FDA has announced new initiatives specifically aimed at supporting drug development for rare diseases, such as the Support for Clinical Trials Advancing Rare Diseases Therapeutics, or START, the acronym START, S-T-A-R-T. This is a pilot program to enable real-time communication between the drug sponsor and the FDA staff on these development issues. Another important initiative of the FDA is the Rare Disease Endpoint Advancement pilot program to support drug sponsors' ability to engage with the FDA around the development of so-called endpoints, the metrics of efficacy for drugs for rare diseases. In the last decade, the FDA has also done more to hear directly from patients with patient-focused drug development. These are meetings that give the FDA staff the opportunity to hear directly from patients about how their disease affects them and what drug effects are meaningful to them in their daily lives. So I support the agency's recent steps, but we should continue supporting and strengthening their authorities and to do more to facilitate more approvals of safe and effective drugs. So I look forward to hearing today's recommendations from our witnesses about the steps we can take to lead to more FDA-approved treatments for rare diseases. So next, we'll move to our witness introductions. I'm pleased to turn to our first witness. Our first two witnesses, I should say, will be sharing their experiences as patients and advocates, but in this case, they will not be answering questions. They'll be providing opening remarks virtually. And for our first virtual witness, I'm glad to turn to Ranking Member Braun.
Next witness, Dr. Anish Bhatnagar is the Chief Executive Officer of Soleno Therapeutics, which is a small biotech firm dedicated to treating rare genetic disorders. He has been with Soleno since 2006. He is a physician with over 20 years of experience in developing biologics, drug-device combinations, and diagnostics, as well as therapeutic medical devices.
Chairman Casey, Ranking Member Braun, and honorable members of the committee, I'm honored to testify at today's hearing. Thank you for inviting me. My testimony today is my personal opinion based on my experience over the years. I'm a physician by training. My 25-year career, almost entirely at small companies, has involved developing treatments for cancer, for neurological, psychiatric, cardiovascular, and other diseases, and for the last several years for rare diseases. None of my work, including that on life-saving cancer drugs, has been as meaningful as working with this amazing community of families who have children and adults with Prader-Willi syndrome. Many of them are in the audience today. While the regulatory challenges across therapeutic areas are similar, there is a much more disproportionate impact on patients with rare diseases. A similar disproportionate impact is seen on small companies like ours, which do a large proportion of the high-risk work. Our ability to raise money and continue work depends prominently on regulatory clarity. If the minutes of an FDA meeting do not clearly state a path forward, or if a company receives inconsistent feedback, it could be the difference between having money to carry out a pivotal trial or giving up on a drug to treat a disease that has no options. Speaking of diseases with no options, Prader-Willi syndrome, PWS, is a rare and life-threatening genetic condition which occurs randomly and affects about 10 to 20,000 patients in the US. Children with PWS are often recognized within weeks of birth. By the age of 3 or 4 years, they will start to show more of an interest in food, which increases over time until they ultimately develop the hallmark symptom of hyperphagia, an insatiable desire to eat, the brain telling you that you're starving even as you eat. Individuals affected by PWS never feel full and are constantly focused on one thing, food and how to get it. Left unsupervised, they have the potential to literally eat themselves to death. Much like a teenager with PWS who recently ran away from home, ate enough that his stomach ruptured and he passed away. The only remedy for hyperphagia is to restrict access to food. Closed kitchens, locked refrigerators and pantries, motion-activated cameras, and alarms. Families live in the constant fear of extreme outcomes like visits to ERs, police intervention, and in many situations, the need to be cared for in an institutionalized setting. Invariably, there is a need for constant supervision for life. Numerous drugs have been tested to treat hyperphagia in PWS in late-stage trials. Each one of them has failed, and many companies have been dissolved. Our drug, DCCR, is a once-a-day pill based on a known parent molecule, which was evaluated in an approval-directed study from 2018 through 2020, ending a few months after the start of the COVID-19 pandemic. The study missed its primary endpoint, but the analysis of the pre-COVID data showed statistical significance in favor of the drug. Long-term data, now up to 4 years in some patients, and comparisons to natural history of the disease show statistically significant and clinically meaningful improvements with the drug. We've been asked to generate additional control data before submitting a marketing application to the FDA. We have just completed the study, which shows highly statistically significant and clinically meaningful benefits of DCCR, and we hope to submit an NDA to the FDA next year. We need a regulatory framework that recognizes the novel, complex, and heartbreaking nature of diseases like PWS. We cannot continue to apply the same regulatory paradigm to all diseases and all drugs. Context must play a role. It's amazing to see new options available for people with ALS and the first approval of a drug for Friedreich's ataxia. But there's also diseases like Barth syndrome, where a drug with promising data may not have a path forward. Regulatory delays, such as the 3+ year back and forth with the FDA, have real-life impacts. For companies like ours, programs will be cut, some will even shut their doors. Every day, every week, every month, every year, symptoms will worsen, sometimes in irreversible manners, and patients may even die as they wait for treatments. The FDA is and needs to remain the premier regulatory body of its kind in the world. What is desirable is a rigorous regulatory process, but one that balances the risk of approving a drug with the risk of having no treatments available for a desperate population. The Promising Pathway Act is a significant step in the right direction. Time-limited provisional approval would allow patients the ability to access potentially life-changing treatments as additional meaningful data is generated to justify their use. Availability of such treatments would be driven by clinically relevant data, and final approval would come only upon rigorous analysis of data generated from patient registries. In closing, I truly appreciate the opportunity to share Soleno's story, highlight the significant unmet needs of the rare disease communities, in particular the PWS community. Thank you for your time. I look forward to your questions.
Doctor, thanks very much for your testimony.
As Senator for Ohio, I'm proud to introduce a great Ohio and a great Cincinnatian, Mr. Keith Desserich. Keith is the chairman and co-founder of the Cure Starts Now Foundation, which is the leading international charity dedicated to finding cures for the rare pediatric brain cancers that may help cure other types of cancers. He is also the president of the Pediatric Brain Tumor Consortium Foundation. He and his wife, Brooke, established their foundation in 2007 after losing their daughter to a cancer called DIPG at the age of 7. Her public battle was memorialized in the best-selling book Notes Left Behind, which was eventually translated into 22 languages. Since then, the Cure Starts Now Foundation has invested more than $30 million in over 130 trials across 17 countries. Keith helped create an innovative, organic, and linked registry that has become a model for other disease registries, and he's advocating today on behalf of public policy facilitating his important work rather than making it harder. Keith is also a steering committee member of the Pediatric Brain Tumor Consortium, the premier NIH-funded brain cancer research initiative. Thanks, Keith, for being with us today.
Thank you, Chairman Casey, Ranking Member Braun, and distinguished members of the committee for the opportunity to discuss the Promising Pathway Act. It's something that I consider vital to our efforts to find the home run cure for cancer. I'm Keith Desserich. I'm chairman, co-founder of the Cure Starts Now Foundation. I'm board member of the DIPG-DMG Collaborative. I'm president of the Pediatric Brain Tumor Consortium, but most importantly, I'm a father. My daughter Elena fought a cancer called DIPG when she was just 6 years old. We had no hope, there were no trials available, and they told us to go home and make memories. Sadly, she understood this as well, fully aware until her very last day that there was nothing that we could do. You see, with DIPG, each day you see your child lose something. One day, it was her ability to be able to see out of her left eye. The next day, it was her ability to speak, then her ability to walk, until one day it became her ability to swallow, to breathe, and her heartbeat. What's particularly cruel about this type of disease is that it affects children, and it's very, very rare in adults. But at the same time, many experts believe that this is a cancer that can show the most promise, at the same time as believing that this is a cancer that they fear most. Universally, for this reason, it is known as a home run cure cancer. We have made it our mission to focus on these rare cancers, building tools from scratch such as a registry that spans 129 hospitals, intelligent patient tools, strategic research, and even virtual hospitals to try to leverage all of the great guidance and intelligence that we can find worldwide to come to bear on one specific patient. And in the 17 years since Elena lost her fight, we have invested in over $30 million in research and support through 135 projects. I understand the perspectives of the researcher. I understand the perspectives of the parents. I understand the perspectives of the registry. I come to you having seen each of these various elements of it, in addition to talking with parents each and every day when they're in their last weeks. I also come to here with hope. I hope for a new way to fight cancer. I believe that the FDA is well-intentioned, but in the end, no one plans for this type of devastating cancer. Sadly, I believe that there's much confusion inherited from bureaucracy, and whether by regulation or guidance clarity, I argue that the system is broken and the status quo will not do. For our purposes, there are effectively only two measures that we can consider when we start to talk about DIPG. One is expanded access, and the other one is right to try. It's important to note that with expanded access or compassionate use, it is not an alternative for the Promising Pathway Act. I know this not only from dealing with the loss of my daughter, but also in calls with over 200 families per year asking for help, any help, in their last and final days. With DIPG, a patient is frequently only given 2 weeks after progression to act. Expanded access requires 4 levels of approval: 24 hours for a family to reconcile with the news, 3 days for a doctor to determine the strategy, 2 weeks for an internal review board to approve a methodology, 3 days for a pharmaceutical company to respond, and up to 30 days for the FDA to effectively approve the entire process. That's 1 week longer than our child survives. It doesn't work. Then there's right to try. It's slightly better with the 2-level approval process, but it lacks data transparency to patients and families with an annual report model that submits to the FDA. We think clarity, we think transparency are cornerstones of being able to find the cure. All of these, though, and the current guidelines assume that terminal means months or years to live. They assume that patients are not intelligent to make decisions for themselves. They assume that data in less than ideal situations are worthless. And they assume that every patient is an adult. And the assumptions are wrong. The reality is we don't get doctors that understand the systems. We don't get a call back on the weekend. And none of these acts were designed for pediatric terminal diseases. The Promising Pathway Act is different. It offers an alternative to FDA-mandated unethical practice of trials giving the wrong drug to the wrong patients for pediatric terminal diseases. Right now, nearly every therapy designed for pediatric cancer is guided through a 3-phase adult trial before we can even get to try it on a terminally diagnosed child. Sadly enough, some of these cancers don't even affect adults like DIPG, meaning that we either misapply a trial on the wrong patients or, worse yet, the drug company simply gives up. Now remember that some of our biggest advances in cancer started with pediatric cancer. You want to know why we can't advance a cure? This is why. The PPA also preserves critical data on outlier participants in a trial and retains it for the use by the FDA, the drug companies, the researchers, and the patients in any third-party registry of substance, thus improving transparency. PPA also addresses insurance coverage and financial burdens in ways that neither previous alternative has. Finally, the PPA, or Promising Pathway Act, advances innovative therapies that may be impossible to subject to current trial design. Keep in mind that trials for rare cancers rarely ever get full accruals, leading us to either give up on good ideas or enrolling children in older trials that we already know don't work. It is not lost to me the value of a clinical trial, but what is lost to many others is the value of a quick and efficient clinical trial. Unfortunately, with rare pediatric cancers, we have to consider both this, and sadly, in their final days, we also have to consider compassion. I have this pile in front of me of grants. These are grants that we have worked to build, to fund at many different institutions. There's 46 of them. This is a pile which has hope. This is a pile which is the dreams of the researchers, and frankly, it could be the lives of these kids. This is 46 chances to be able to cure cancer. And sadly, the whole reason why I'm here today is because I believe that these 46 opportunities to be able to cure cancer may never reach bedside unless we get PPA passed. I'm a big believer in personal initiative, but in this case, we may be able to go no further unless government gets out of the way. The promising pathway is how we do this. Families are desperate for another chance, a chance at seeing their children go to kindergarten, a chance to see their child get a driver's license, a chance to see them graduate from high school, a chance to see them go to college and get married. We want a chance to see them grow up. Rarely do you have a chance or a bill that asks for no money, and the money is not really part of what we're asking for. This is that rare case when you can act to give patients fighting for their lives the power to save their own lives. I lost my daughter, but I refuse to believe that we cannot save others. You've heard today from some very compelling and well-educated witnesses. I'm the only one, however, that has lost everything in this and was given no options because there wasn't any. There was existing barriers that were either too cumbersome or our policies were built around the majority. And while some of these numbers may appear small from the aggregate, in the end, it is with this type of cancer that experts also believe that we will have the greatest impact to be able to cure it. And so what we may ignore may be precisely what must save us. The Promising Pathway Act may be the single biggest piece of legislation that costs nearly nothing, but may change everything about how we win this war against cancer. Thank you.
Mr. Desserich, thanks so much for your testimony and for sharing the story of your family and your daughter.
Thank you.
Next question will be for Mr. Desserich. Thank you for sharing your story. Sorry for the loss of your daughter. Your advocacy, though, of course, means a lot to her and her legacy. Do you feel that any current drug approval or access programs at the FDA address rare terminal pediatric cases like DIPG?
I don't. That's the reason I'm here. I'm here because there isn't anything that applies to this. I mean, the amount of patients that we talk to that are reaching out to us, and they're reaching out to us partially because they're not getting any answers from medicine or drug companies or anything of that sort. It's almost impossible at that point. And it's because of really two things. One reason is because of time. We don't have that time. We have 2 weeks. Nothing gets done in those 2 weeks. I've had so many times where I've seen a compassionate use has been approved for a patient, but it usually comes in several days after the patient has already passed. You want to talk about a difficult call? That's a horrible call to make. I've also seen where it doesn't address anything having to do with pediatric. We write laws with the idea of adults. And if you look at any of these guidelines that we have put forth through the FDA, we grant waivers for them not to do it in pediatrics, but we never go the opposite way. And so because of that, we have to wait, and we have to hope that it can go through all of the adult trials first before it can ever get to a child trial. And so it never gets started. And so at the end of the day, we can't get access to those drugs. The time is not the right amount of time, and the children are being ignored in this. And it shouldn't be that way.
On these diseases, mostly smaller companies address them. It can be billions of dollars, years to submit a new drug application to the FDA. Larger companies generally don't do it. Tell me a little bit about, is the market cooling for this due to the fact that we got a process that is stubborn and bureaucratic?
Thank you, Senator, and the answer is yes. There are parts of the biotech ecosystem that are doing well. I mean, science is robust. Patient advocacy is stronger than it's ever been before. But what's cooling is the funding environment. And you can see that if you look at the XBI, which is a gauge of public companies, it's down more than about 30% this year. This may be the third year in a row it's down at a stretch, which would be the first time that's the case since it was first conceived. Number of companies going under has been phenomenal. Number of layoffs has been extraordinary. So yes, the ecosystem is
And would the
cooling.
Promising Pathways Act address that in a way that would be meaningful so we at least keep businesses in business to try to work on these ailments?
I think so. When you think of why that's the case, I think the uncertainty in the regulatory environment is a big factor for rare disease companies. Companies like mine, we work on 1 or 2 programs. And if you don't have the clarity, then it's hard to get the funding to do the work. So yes, if there is a pathway that is more certain, it would definitely help.
Thank you. I yield back.
Thank you, Ranking Member Braun. I'll next move to my questions. I also wanted to note we obviously have a number of senators who've been here. Some have been here and won't be back. Some will be back. But after my questions, in order of appearance, we'll go to Senator Scott. We've also had Senator Gillibrand, Senator Blumenthal here. And let me just go to my first maybe 2 questions. Dr. Bhatnagar, I wanted to ask you a question, but as a predicate for that, I understand that one of the challenges in rare disease drug development is that there are often very few true experts in the disease, and that this presents difficulties at different stages of the drug review process. FDA has acknowledged these challenges and indicated they're open to revising some of the policies to ensure clinical expertise for rare disease therapy. So, Doctor, here's my question. As you've worked through this drug development process, are there areas where greater expertise in rare diseases like, as you mentioned, PWS, Prader-Willi syndrome, among FDA expertise for that syndrome, among others, among those FDA reviewers, are there instances where that would be helpful, that greater expertise?
Thank you, Senator, and yes, it would be helpful. When you're dealing with a disease like Prader-Willi syndrome, we don't expect that there would be expertise at the FDA because it is a rare disease. So we would hope that there is that understanding and the idea that from the very beginning of the process, there would be experts at the other end. That's not been the case. We generally take physician experts with us, but unfortunately, they're considered to be conflicted. The problem in rare diseases, which is very different from other large mass market type of diseases, is that you generally involve all experts in the clinical trials. Otherwise, you would not be able to enroll those trials. So if you believe them to be conflicted, then who would be the expert? So I think this is one not very difficult thing that can be implemented. You can take their opinions with a grain of salt, but at least consider them to be not conflicted and speaking for the disease.
Doctor, thanks very much.
So, Dr. Butner, what can Congress do to expedite the delays that you're seeing?
Thank you, Senator. Firstly, I want to just acknowledge that Florida is the epicenter of PWS care in the world. The University of Florida has a physician by the name of Jennifer Miller, who sees the largest population of PWS patients in the country. To answer your question, it's probably true that the FDA already has the authority needed to provide regulatory flexibility in the circumstances that we're talking about. Unfortunately, there is no consistent application of that flexibility. So I don't know what tool it takes, but I think to mandate the consideration of regulatory flexibility in all rare disease applications is valuable. I think to work with experts to define for a given disease setting what that flexibility should look like is important. And then to come up with an enforcement mechanism to ensure that it's happening is important. So I'm not sure what tool it takes, but I think conceptually that's how I would go about it.
Yeah. Well, in May of this year, I joined you with 24 of my colleagues in both the Senate and the House asking for change at the FDA. We requested a task force be developed to include leaders from all divisions, offices, and centers which process rare disease therapy. applications to fully examine areas of policy and procedural inconsistency and shortcoming to see what we could do better. We also asked that the task force provide Congress recommendations. The FDA disagreed with our request to form a task force. They said they're going to share relevant reports. But I think a lot of times up here, people do have the authority to do the right things. It's just the way the process is set up. And then there's no accountability that it doesn't work the way it's supposed to work. So, the more specific you guys are to any of us, the greater chance we're able to get something done. So do any of you know what type of patient experience the FDA collects in its clinical trials, and how's the FDA use that? Does anybody have any ideas?
I think patient experiences can be collected in a variety of ways. One of the newer mechanisms which the FDA has been using is a patient-focused drug development meeting where the FDA attends and listens to the patient populations about the unmet needs, et cetera. During trials, in trials like ours, we collect patient information based on questionnaires, looking at symptoms and signs that are relevant. So the agency definitely has a lot of that evidence in their hands. Real-world evidence is something that they've been discussing, but it's been part of very small number of applications for approval, and it's certainly not been the primary way any drug has been approved so far. Dr. Lynch, if you have something to add.
I think from the discussion you've heard today that it's clear that there's a difference between the broad array of diseases out there, the places where most pharmaceutical companies go, and that with everything we're talking about here, it's just not being addressed. And Keith, I'd like you to comment on, is the paradigm that we have currently working? And especially in the case of one with a narrow window of survival, and within the paradigm that is, to me, bureaucratic, has not responded in a way to these over a long period of time. Is there any hope that we can get it done within that current structure?
I think that the comments that we were talking about of what's being collected and also comes down to the guidance as opposed to regulations, and as was pointed out, the idea that it probably could be done in the right way, but unfortunately it isn't. And I think that
and is that called compassionate use in the current framework?
Yeah, I mean, I guess it could be. They could take any of these measures and they could probably try to bend it with it, but it doesn't happen. And I think that's the reason why PPA really needs to be there, is because otherwise, without it, there's nothing that's going to make sure that there's any accountability to deliver the right decision on it. We witness this time and time again. I've talked to drug companies, and they tell me they can't figure it out. They feel that what is in the guidelines versus what is in the guidance or the suggestions that they receive back is not matching up. I talked to a drug company just last week, and they said they're probably not going to be focusing on our realm and on pediatric drugs.
And that's why we need the formality of PPA.
Exactly, because they see no way that it's going to work, and they're giving up, and we can't have that. These are small drug companies, but that's where sometimes the best ideas come from. And if we take away the opportunity to consider those good ideas, that's a problem. And I think the other thing that we miss is really the patient right type of thing. We talk about data collection. We talk about the idea of being able to have it at the pharmaceutical level or in the FDA. Data isn't the property of one entity or another. There has to be also a patient element to this. That's the beauty of what is in the Promising Pathway Act, is also the international register, or these registries that are in there, these independent registries, which allow for everybody to be able to communicate that, but still protect the patient privacy at the same time. And otherwise, we're just going to get half of the information. We're going to be following what we think is necessarily the guidance on it. And effectively, what we're left with is a Wild West type of mentality as to how we deal with drug trials. And we can't keep doing it that way, because if that's the case, we're never going to be able to get anywhere on this.
Senator Vance.
Thank you, Mr. Chairman, and I'm going to direct my questions to Mr. Desserich. So, first, let me just say, I've got a 6-year-old, a 3-year-old, and a 1-year-old, and my heart goes out to you because I know that you've engaged in this fight because you lost a 7-year-old daughter, and I know there are a lot of other folks here who've lost kids, and my heart goes out to you as well. The goal here, of course, is to try to get to a society where no parent has to bury their own kid because of an illness that's currently incurable. I know we're all working towards that goal. And the worry that I have is that given the limited patient populations, because some of these diseases are incredibly rare, and because of how differently we treat pediatric illnesses and the medicines to treat pediatric illnesses, that we're making some mistakes here. And I know, Mr. Desserich, there is an argument that the right to try legislation, the expanded access that happened during the last administration, which I think was a good thing, that satisfies some of the concerns that you have with the current way in which we give patients access to these drugs. I'd like you maybe just to explain why that's not right. What are we still not doing correctly in this space?
Well, I think anytime that we've tried any of the right to try elements within our specific disease classification, there's been an unwillingness to make it apply to pediatrics. You know, right to try seems to be something that may have some adult applications to it, and I can't really speak to it because I don't touch those populations. But within the pediatric realm with it, everybody's kind of looked at it and said, well, yeah, it's not going to go for children's cancers. And I think that's, that's really the cornerstone of everything that we're talking about here, is because I think what we tend to do is we tend to think it along the lines of the ideal circumstance. We think of it as a clinical trial and how these can be perfected and how we can do better with it. But at the end of the day, all these acts and all these regulations are dealing with imperfect scenarios. A clinical trial requires things such as investment, accrual, time, biomarkers, and certainly a completion. And the issue is while we all, I think, see the need for clinical trials, we're dealing with scenarios to which these things don't exist. We can't get it. We can't get accruals. I mean, I'm witnessing right now a trial that we're putting out there with kids in our disease classification, and they have an accrual number of 400 patients. We only have 400 kids that are diagnosed per year. That means this trial is never going to get finished. It's going to have 8 years to be able to get there, and by then we're already going to know whether it works or doesn't work with it. And so you can't think of it in those ways. We have to go into this with the idea that we don't have the things to do the clinical trials sometimes. And so Promising Pathway effectively fills that need.
So, Mr. Desserich, can you explain to me just this particular point? So very often, and I've worked with companies, and in my private life, my prior life, I should say, when I was in the private sector, we actually worked with some biopharmaceutical companies doing clinical trials. One of the things, of course, you're trying to do in some of these cancer therapeutics is identify whether the addition of the therapeutic increases the life of the patient, right? It's one of the primary endpoints oftentimes. But in some of the diseases we're dealing with, especially in pediatric cases, extending the time from 3 months of life to 9 months of life is not really practical because the time given for the individual patient for a child is so small. So the idea that you're going to somehow reach a classic adult endpoint in a pediatric case sometimes just doesn't make any sense, does it?
Absolutely not. I mean, we can't reach those endpoints. I mean, frankly, I think our community is happy with anything that we can add. I mean, just another day is what we're looking for.
Sure.
And we've seen some things that have worked, that we've applied, and we try to do this with. And they've added months. Right now, I would guess from looking at some of the registry data, we see that they've probably expanded that by threefold, and that's good. But we were only talking about, maybe 6 months. So threefold is a year and a half. That's not a life by any stretch of the imagination. Will it ever be at that case? So it's just, we have to take it and we have to try to grow it as much as we can.
I appreciate that. I appreciate all of you for being here. And the last comment I'd make here is that we all understand that we have to do better. And what occurs to me just in looking at the Senator Braun's PPA and just talking with Mr. Desserich, both in this context and in others, is that we have a clinical trial situation. We have a clinical trial infrastructure in this country that's in some ways designed for adult diseases and very common diseases. And if we don't fix the underlying infrastructure, we may have a lot of kids out there who are languishing, who are dying, not because there aren't therapeutics and not because there isn't capital to invest in these new therapeutics, but because the regulatory regime doesn't allow us to actually try these things and figure out whether they work. I think we need to fix that problem. I applaud Senator Braun for trying to take a swing at it.
If I may add something to that as well with it, the other thing I think that we also miss is that for the most part, we view our kids as not the same level as an adult case. And so what we do is we tend to say, let's take a drug that we know works in some other cancer and let's give it a try in kids. And okay, for that, we can do clinical trials. For those, we can put them out there. But what happens most often is, especially right now, with all the knowledge and all the investment that we put into this and the registries and the tracking and the patterns and everything we've been able to find, for the first time, we have an ability to craft a drug that focuses on DIPG. But now, I can't get it out. I can't get it to a bedside because I can't put it in adults. Adults don't normally get this. So we're at a stop point. You know, by reference to you, and the reason for bringing these 46 grants is to impress upon you how important it is, because I don't think I can get a lot of these into a clinical trial.
Mr. Desserich, how would the Promising Pathway Act improve access to life-saving treatments for patients who have serious diagnoses? And I ask this, recognizing that you have been personally impacted by this, even as you remember your own daughter. And so let me thank you for translating your pain into power and being such an important voice on this. And so from your experience, how would the Promising Pathway Act help?
Well, I think in our case with it, it's a question of time and direction towards pediatrics. I think everybody looks at this as the Promising Pathway Act as an ability to be able to find something that generally satisfies the safety requirements, and we can try to move it towards giving it a conditional approval. So we're certainly moving that up, and I think that helps any patient in a terminal diagnosis. And with regards to the pediatric side of things, what Promising Pathways does that I think better than others is it allows it to move faster into the pediatric realm especially in those rare and terminal cases. Now, that's not all cases. There's also some specific definitions of what is a terminal case in this that I think really help to provide some clarity to it. But short of that, we can't get it there. We can't get these trials into the pediatric realm with it. We need a perfect, ideal scenario, and the cancers that we're dealing with are absolutely nothing close to ideal. It changes everything.
Last question, Dr. Botniger. So often you hear folks have to leave the country to get leading edge treatment. That's a shame. We should be that leading edge, and we should have a system that accommodates it. Could you talk about the difference between our system and one that seems to be working better, which would be in Europe, in terms of how they've done provisional approval? And please comment on that, because if that's better, we should at least be emulating that.
Thank you, Senator. It's a good question, and I think it's debatable which one is better. I think it is true that there are certain therapies where access is more elsewhere. I think our regulators are clearly top-notch. The world looks up to the FDA for what they're going to do. But I think there are times when there are delays which are unnecessary. There are situations such as approving drugs early in the process where we don't have the same considerations. So just very quickly, because I know we're almost out of time, The accelerated approval pathway, as it exists in the US, really is focused on two constructs. One is you have a known biomarker or a surrogate that predicts benefit. And the second is an intermediate clinical benefit that predicts ultimate use. The challenge with both of these is that neither of them is really present in most rare disease situations. Last year, CDER approved 37 drugs. 6 were accelerated. 5 of them were oncology drugs. 1 was a non-malignant hematology drug. The point is that oncology is an area where these diseases are really well understood. Other rare diseases, we cannot use the pathways. Europe has prospectively defined certain things that they can do on a regulatory side. You can negotiate a study design with the regulators prior to approval and get an approval in that manner. We don't have the same provisions.